So indeed, I'm going to present some, not all, but some of the highlights from the American Heart Association meeting, and picked a few topics that we can cover off. First, my disclosures, which are many. As always, a number of the companies that I work with provide research grant support to the research organizations that I work with and that were highlighted on that first slide. But I also personally receive some speaker and consulting honoraria. So as always, take what the speaker says with a grain of salt. All the details of my relationships financially with industry and my roles in working with them are outlined on the Canadian VIGOUR website out at the University of Alberta online, back down in the right-hand corner. And so the objectives for today, to review some of the key presentations in cardiology and cardiovascular medicine from the American Heart Association scientific sessions at the mid of November 2025, and then hopefully more importantly discuss the potential implications for the management of patients with atherosclerotic cardiovascular disease, ASCVD. I'm going to focus on some patients who have had myocardial infarction and chronic coronary syndromes as manifestations of ASCVD, and we'll also cover off a couple of two or three interesting studies as it relates to atrial fibrillation, and discuss all these implications, hopefully relevant to your clinical practice. There's a lot of great stuff that came out of the AHA, and as always for these rounds, I'm really trying to pick out things that were interesting, but also generate some discussion because I believe they have some impact from a clinical perspective on a day-to-day basis for many of us. So one of the kickoff late-breaking trial presentations was by Aaron Bahula, part of the TIMI group at Harvard, on behalf of the Vesalius cardiovascular investigators. And you can see underlined here the acronym Vesalius CV relates to the effect of Evolocumab in patients at high cardiovascular risk, but without prior myocardial infarction or ischemic stroke. And so the background is well known to everybody. I won't belabor it. LDL is obviously a well-established, modifiable, and causative cardiovascular risk factor. We know that lowering LDL cholesterol with PCSK9 inhibitors, including Evolocumab, can significantly reduce the risk of cardiovascular events in patients who have a prior major atherosclerotic cardiovascular event, such as MI or stroke. And you'll recall from the FOURIER trial that 81% of the 27,000 patients enrolled in that trial had a prior myocardial infarction, and some had stroke as well. But the clinical benefit of intense LDL cholesterol lowering with PCSK9 inhibition in patients who have not had a prior MI or stroke is unknown. And so here's the ASCVD continuum, and you can see in the right-hand side, of course, major atherosclerotic cardiovascular disease events like MI, ischemic stroke, or symptomatic peripheral artery disease, well covered, I would say, with PCSK9 inhibition and cardiovascular outcome benefit in the FOURIER and Odyssey outcomes trial. But Vesalius, while it has a little bit of overlap, did not specifically include patients with prior MI or stroke. And in fact, arguably, one could say, although this is maybe an outdated term, moving from secondary prevention upstream earlier on in the process of atherosclerotic cardiovascular disease and risk in the so-called primary prevention arena. For example, those with diabetes and additional one or more additional cardiovascular risk factors, it's a bit more unclear in the patients without known or yet manifest ASCVD whether there is a benefit of intense lowering of LDL cholesterol, particularly added on top of statin therapy. So Vesalius trial design, as published a couple of years ago in the American Heart Journal, was aiming to take over 12,000 stable patients at high risk for cardiovascular events, but without prior MI or stroke. And so if they also on optimized statin therapy plus or minus ezetimibe had an LDL cholesterol translates to above 2.3 millimoles per liter, or other atherogenic lipoprotein elevation concentrations above guideline recommendations, they were eligible to come into the study. They were randomized to receive every 2 weeks standard dosing of Evolocumab compared to a matching placebo. And this was an event-driven trial with two co-primary outcomes, the 3-point MACE that's listed there and the 4-point MACE that I'll outline, which basically is coronary heart disease, death, MI, or ischemic stroke, but added to that, ischemia-driven arterial revascularization. I just want to make a shout out to Canadian participation, which was modest but important. And underlined here are the two Canadian investigators that are at our homes here at the University of Toronto. So Andrew Yan was a site investigator, and he and Jay Udell at Women's College contributed from Toronto specifically. This was obviously a large international study with participation from almost 750 sites. I won't show you the distribution of the baseline selected characteristics related to the two treatment groups, placebo versus Evolocumab, because you can imagine with 12,000 and change patients, the distribution was evenly distributed. But I will point out that this is a population who is on average 66 years. They got better representation than most trials in this space do as it relates to female, to women. 43%. Diabetes is part of the inclusion criterion for at least one of the higher risk features, so unsurprisingly that they're overrepresented here. Not to say that ASCVD patients, 58% of them have diabetes, but a good proportion in the Vesalius-CV trial had diabetes. And if you look at the qualifying disease categories, again, there is some overlap here because it's not mutually exclusive. You could obviously have coronary disease without prior MI, maybe also have peripheral artery disease, maybe also have diabetes. But importantly, the bottom two rows amongst the high-risk diabetes patients and those specifically without qualifying known manifest atherosclerosis, a third of the 12,257 patients qualified on the basis of, again, what we would arguably say in the past would be a primary prevention group of patients, so earlier on in the course of their atherosclerotic cardiovascular disease. They all were supposed to be on lipid-modifying therapy, at least maximally tolerated statin. 2/3 of those who were on a statin were on high intensity, and yet you can see in the bottom right-hand panel, their LDL cholesterol, non-HDL, and apolipoprotein B were all elevated. And we'll come back to this because one wonders whether there's a lot of folks here on high-intensity statin whose average LDL cholesterol is 3 and above, who might have, for example, familial hypercholesterolemia. This is a lipid substudy plot in 2,000 of the 12,000 and change patients that had a baseline median LDL cholesterol of around 3. And you can see at the infrequent visits that were a study mandated over the course of time, by 48 weeks, there is a fairly dramatic lowering of LDL cholesterol down to a median of 1.16 with Evolocumab. And this corresponds to a 55% relative reduction compared to the baseline LDL cholesterol, and perhaps more importantly, an absolute reduction of over 1.6 millimoles per liter. Now, this again is in a sub-study that was done to look at lipids over time. This is a cardiovascular outcome study, so they didn't want to mandate for all 12,000 patients that they have frequent assessments of LDL cholesterol. We already know that there's early and sustained lowering with Evolocumab and that this is well tolerated. But if you again look at the overall trial population based on local laboratory, their baseline median was 3.16 millimole per liter. And so we can estimate based on what we can see in the sub-study that the absolute reduction, at least in the overall trial population, was getting close to 2 millimoles per liter, 1.74 millimoles per liter. And again, this is a really important point that we'll come back to when you see how dramatic the impact is on clinical cardiovascular outcomes. So here you go. Here's the first of the dual primary endpoints, the 3-point MACE of CHD death, MI, or ischemic stroke. There was a 25% relative reduction and an almost 2% absolute reduction out to 5 years' time with Evolocumab in red compared to placebo in blue. A reminder, everybody or almost everybody is on background statin therapy. A large proportion are on high-intensity statin therapy. Ezetimibe is used in some of these patients, and they're getting all the other secondary prevention therapies that you might imagine in the group that have established atherosclerotic cardiovascular disease. Similarly, there was a 19% relative reduction in the 4-point MACE when you add in ischemia-driven arterial revascularization. And those are listed here in the hazard ratio plot. But I just want to show you some of the key secondary endpoints which they tested statistically in a hierarchical fashion. And so a bunch of different composites showing a consistent benefit in the same ballpark range. Myocardial infarction reduction alone was significant. Ischemia-driven revascularization alone was significant. And then we hit coronary heart disease death, which crossed 1.0, the upper confidence interval, so not a statistically significant difference. And so all of the subsequent individual endpoints, including cardiovascular and all-cause mortality and ischemic stroke, were considered nominal. This is because of the hierarchical testing. Once you hit one of the components as being not significant, essentially the argument is everything beyond that is hypothesis generating. But I think we can all agree that a 20% relative lowering in cardiovascular and all-cause mortality, regardless of what the p-value ends up being in a 12,000 patient study, is probably very meaningful from a clinical standpoint. And here's the Kaplan-Meier curve. Again, it's listed as a nominal p-value, but there is clearly an advantage from an all-cause mortality perspective of Evolocumab compared to placebo. The 3-point MACE and 4-point MACE pre-specified subgroups are all showing consistent results. So this just means that at the end of the day, regardless of whether you're older or younger, whether you're male or female, whether you're qualifying atherosclerotic cardiovascular disease or high-risk diabetes with another additional cardiovascular risk factor, et cetera, you can see great consistency of relative benefit of Evolocumab over placebo. When you plot the Vesalius-CV results on the infamous cholesterol treatment trialist collaboration meta-regression line on the left-hand panel for major coronary events, on the right-hand panel for major vascular events, you see that Vesalius in red lines up very nicely. And so this is PCSK9 inhibition with Evolocumab on top of statin plus or minus ezetimibe therapy. But because you're getting such a large absolute reduction in LDL cholesterol in the 1.5 up to 2 range, depending on which subgroup you look at in Vesalius-CV, you see actually greater proportional reduction in event rates than the dotted line, the infamous 1 millimole per liter at 1 year's time reduction, with, for example, statins translating into about a 20 to 22% relative reduction in major coronary events and major vascular events. So you essentially get a bigger bang for your buck from a clinical event reduction perspective in this patient population, in a large part because Evolocumab is driving the LDL cholesterol down on top of statin plus or minus ezetimibe so dramatically, 1.5 to 2 millimoles per liter in absolute terms. So the conclusion of the investigators is that while guidelines have progressively recommended lower LDL goals of 1.8 or 1.4 millimoles per liter as per the European guidelines in very high-risk patients, and in extreme risk patients that the ESC guidelines have highlighted for us, including post-acute coronary syndrome patient population, for example, trying to achieve an LDL cholesterol below 1 millimole per liter is often not going to be achievable with statin therapy alone, and yet it is worthwhile to drive it down to that approximate level, at least based on the Vesalius-CV results, because when you got on average an absolute level of LDL cholesterol of 1.2 millimoles per liter in the Evolocumab arm, you're seeing dramatic reductions in major adverse cardiovascular event rates, including cardiovascular and all-cause mortality. So this study was published simultaneously, and all the details are available on the New England Journal website. I just wanted to finish up by again pointing out this is one of the slides that Aaron showed that wasn't completely detailed, and I'm sure there'll be some additional analyses published, but wasn't completely detailed in the New England Journal paper that I think is really interesting. And again, just to point out that we're pretty familiar with patients with established atherosclerotic cardiovascular disease, but there's 45% of the population who have established ASCVD but have not yet sustained an MI, have not yet sustained an ischemic stroke, who clearly dramatically benefited from therapy here. And then even coronary artery calcium score was one way to meet the eligibility criterion around qualifying ASCVD. And so this is consistent with the Canadian cardiovascular guidelines going back many iterations, not just the contemporary one, that says that the definition of ASCVD is not just prior myocardial infarction or ischemic stroke, but any type of disease. It doesn't mean you have to have 100% occlusion or a 70% narrowing in a coronary artery to warrant considering that these patients are at high risk, and that risk can be mitigated substantially by lowering LDL cholesterol. And so in the continuum of ASCVD, from the kind of primary to secondary, which again is probably an outdated terminology here, but in the spectrum, Vesalius-CV has now given us information beyond what FOURIER and Odyssey Outcomes did, that there's a very broad spectrum and a large population of patients with ASCVD where there is clearly benefit in intensifying LDL cholesterol lowering therapy, adding a PCSK9 inhibitor, in this case Evolocumab, on top of statin therapy as early as possible in the atherosclerotic disease process. So essentially more intensive lipid lowering even earlier in the course of ASCVD is better to reduce ischemic events. Now, just before I pause and open up to questions on the lipid side of things, there were a couple of presentations that were very interesting. One that was published simultaneously and one that was just presented that will be published soon in the New England Journal. But there was an oral PCSK9 inhibitor. One of the barriers or perceived barriers to administering PCSK9 inhibition, of course, the biggest challenge is access to therapy and cost, but some people have argued, well, an injectable every couple of weeks or once a month or maybe every 6 months is still a challenge for those needle phobic individuals. And so an oral PCSK9 has been developed, and there are two cardiovascular studies that focused on LDL cholesterol lowering, not clinical cardiovascular outcomes. Those trials are ongoing, but two studies that were presented with enlicitide from Merck, a phase 3 coral reef lipids trial in ASCVD patients, and on the right-hand side, a familial hypercholesterolemia, HeFH patient population. And you can see that in both trials, with this oral preparation, there is really excellent early and sustained lowering with a daily oral preparation of a PCSK9 inhibitor. So stay tuned. I won't give you the details of these studies, but that's the bottom line. We will have additional therapies that can dramatically lower LDL cholesterol further, with the hope that these will translate into cardiovascular outcome benefit. So let me actually pause there for a second, and rather than saving up all the questions till the end, since I've covered off in rapid fire fashion some new information as it relates to LDL cholesterol lowering, let me invite the audience to take themselves off mute, fire off a question, or put something in the chat function as to whether they have any, whether that tweaked their interest. take advantage of this. It's part of your, did the speaker allow 25% of the presentation of the time to discuss this?
Shaun.
Kim, go ahead.
What do you think about this in terms of access for PCSK9? How are we going to, get that inflection point? Because obviously this is a game-changing clinical trial. Where are we at with that?
Yeah, no, great question. So, of course, one has to get a 2 thumbs up from CADTH, now renamed the Canadian Drug Agency, that then allows a recommendation to the provinces, except for Quebec, they have their own process, but to the provinces, and then that allows the drug company, in this case it would be Amgen that makes Repatha, the brand name for Evolocumab, would allow them to negotiate with the Pan-Canadian Pharmaceutical Alliance, PCPA, which they've done successfully for a specific patient population, not this Vesalius-like population, but the subgroup of patients who were in the FOURIER trial that had a quote-unquote recent MI. In other words, an MI within the prior year. So there's a few thousand of those patients from FOURIER that were in that particular subgroup. And so Amgen Canada has gone to CDA, has gotten the recommendation, has then gone to the PCPA, and has now got a recommendation for them to allow them to negotiate with each province to potentially get public coverage. So in Ontario, for example, 65 and older and those on social assistance who are a recent myocardial infarction, defined as up to 1 year post-MI, whose LDL cholesterol remains above guideline recommended threshold, 1.8 millimoles per liter, and who is on maximally tolerated statin. So there's now at least a foot in the door, and I'm cautiously optimistic as they were able to negotiate for provincial coverage for heterozygous familial hypercholesterolemia for Evolocumab and the other PCSK9 inhibitors. I'm cautiously optimistic that this very high risk and big bang for the buck benefit and cost effective in this patient population that we might start to get coverage. But unfortunately, the Vesalius patient population is too far upstream, and I think too broad a patient population right now for Amgen to get leverage, I'll say, with CDA. But I think it's going to help move the needle.
Yeah, thanks. Just one last quick question. For Leqvio, when is the outcome trial going to report out for another? I mean, I know that's in the secondary prevention, but just in this space, there's a lot happening.
Yeah, great question. So Leqvio is the brand name for inclisiran, which is a small interfering RNA PCSK9 inhibitor, just for all the folks in the audience who might not be as familiar with that. It inhibits the production by the liver naturally made PCSK9, and so it's an effective LDL cholesterol lowering therapy that is given 3 times in the first year and then every 6 months thereafter. So basically every 6 months injection. It has a slightly more modest LDL lowering, about 50% relative lowering compared to 55 to 65% with the monoclonal antibodies. But again, really impressive LDL lowering. There are 2 phase 3 trials that are ongoing that Kim alluded to. The Orion 4 study led by the Oxford and TIMI group, and then a study called Victorian to Prevent that I'm on the executive committee for and leading in Canada. And both trials have finished recruiting, and both trials in these endpoint-driven studies are, we hope, in the tail phases of having enough events, including cardiovascular and all-cause mortality. So we're hoping in later 2026 or early 2027 that both of these trials will have enough endpoints to complete, to unblind, and to present findings. So hopefully in the next 18 months. Great. I don't see anything else in the chat function, so unless there's any other questions, thanks, Kim, I will reshare my slides and we'll move on to another topic. Oops, I don't think that worked. Sorry, bear with me for 1 sec. Okay, so I wanted to talk about beta blockade next. I shared some of the trials with you the last time we talked post-ACC. So the question is, death, taxes, beta blockers, are they all still inevitable? There was a meta-analysis of the recently presented and published beta blocker continuation or initiation post-MI versus beta blocker withdrawal or discontinuation or not initiating up front, but specifically in those patients who had a preserved left ventricular ejection fraction. And I just want to note Dr. Christensen kindly shared these slides with me because you have to pay hundreds and maybe $1,000 to get access now to the online slide sets. So what they did is they looked at their 5 recent trials, 4 of which included patients who had a left ventricular ejection fraction that was quote-unquote preserved post-MI within 14 days. This was within the EF range for this previous meta-analysis that I shared with you following the European Society of Cardiology Congress and was published in The Lancet, was for patients with an EF between 40 and 49%. Those 1,800 patients were a minority of the overall trial. And so this current meta-analysis that was just published at the AHA and presented is what I'll share with you. But just so you're aware, in the 40 to 49 range, those patients who continued or were initiated within 14 days on beta blocker, depicted in the red Kaplan-Meier curve line, had a significant reduction in the primary endpoint of all-cause death, recurrent myocardial infarction, or heart failure, compared to the blue line, which were patients who had their beta blocker discontinued or didn't ever have it initiated in the first 14 days post-MI. And that was driven, at least numerically, by reductions in all components. In other words, there were numeric reductions in all-cause mortality, reinfarction, and heart failure. But what about the majority of the patients who had an EF of 50% or more? Is there value in continuing beta blockade or initiating beta blockade peri-MI in that patient population? So these patients were followed up for 3.5 years' time from many different countries that were in the different trials. I just want to highlight that the median age was understandably a little bit younger in those whose EF was higher, and women were a little bit less represented. Only 1 in 5 were female. Most of these patients, all these patients had a myocardial infarction, and it was about a 50-50 split as to whether they were a STEMI or a non-ST segment elevation myocardial infarction patient. However, the majority of the patients were revascularized for their index myocardial infarction and were on other good secondary prevention therapies. In these trials, it was the beta blocker was left to the discretion of the treating physician, but bisoprolol or metoprolol were the 2 most commonly utilized beta blockers. Now, in contrast to the meta-analysis of these same trials that I just showed you, where the EF was between 40 and 49, that there was a benefit in death MI or heart failure hospitalization, here we see no difference between initiation or continuation of beta blocker in blue or discontinuation or no initiation of beta blocker in gray. So very different in this subgroup, including for the individual components. Pre-specified subgroup analysis was consistent regardless of sex and age, and that's important because one of the large trials that's included in this meta-analysis, and I shared some of this data with you after the ESC, had suggested that there was a difference and females appeared to differ in their response compared to males, and similarly older patients seem to do differently than younger individuals. When we pool all the trials together, at least if your EF is 50% or above post-MI, it does not seem to matter at all, and including for the type of myocardial infarction or whether you were previously on beta blocker therapy. Now, there's limitations, of course. These were predominantly bisoprolol and metoprolol. Very few patients were prescribed non-selective beta blockers like carvedilol and propranolol. The average beta blocker doses in the active arm were low. And there was crossover that went both ways. In other words, patients randomized to receive or initiate beta blockade, some of them were discontinued. And similarly, those who were randomized to not be initiated or discontinue beta blocker, there was some crossover. And that would tend, in any trial, if there's crossover, to make the lines more superimposable, which we saw, at least for the preserved ejection fraction of 50% or more. But their conclusion is that if you're post-MI and your EF is 50% or above, it does not support initiating or continuing beta blocker therapy. But I will point out that that contrasts, again, with the meta-analysis and the data from these trials where the EF is 40% to 49%. And of course, what has not been studied contemporarily is if you have a reduced ejection fraction and post-MI, and those studies were done in the 80s, and of course we now know that beta blocker therapy, even in the absence of recent myocardial infarction in heart failure with reduced ejection fraction, is life-saving. And so really anybody with an MI and an EF below 40% absolutely should be considered for a beta blocker, and arguably those up to 49% should probably continue to be prescribed or continue on beta blocker therapy post myocardial infarction. So again, I'm going to pause here for a second before we shift to the topic of atrial fibrillation and see what people's thoughts are on beta blockade. There are some more studies, including one, an outcome study coming out at the American College of Cardiology meeting. But so far, the totality of the data, at least in aggregate, I think is fairly clear now as to what our somewhat arbitrary cutoff might be post-MI for initiating or continuing beta blocker. But interested in people's thoughts. I don't see anything in the comments.
How about
question. Go ahead.
So how about those patients who have initially very bad LV or LV that is less than 50 and then recovered after revascularization or without? Then how will you deal with those?
Yeah, no, great question. And that's, another of the limitations of all of these trials is it's, on the one hand, it's pragmatic and practical. They took some sort of assessment. I presume, we don't even know, but we presume that the ejection fraction was estimated based on echo. But by whatever means it might have been, in the setting of acute myocardial infarction, this is just one snapshot. We don't even know the exact timing in hospital as to when it was performed. And so in the MI setting, particularly if patients have been reperfused and or revascularized, there may be an improvement over the course of time. So if their EF was below 40%, they would not have been eligible. They would have been screen fails in all of these trials, Qiming. And so we don't know the answer to your good question, which is, okay, their EF was below 40. They didn't make it into the trial, but many patients will recover some degree of LV function. And so would it be safe to, once their EF recovers, to withdraw beta blocker therapy or not initiate beta blocker therapy? And we don't know. I would say that one other thing that in some of the studies has been quality of life. Of course, patients don't want to take another drug once a day, the pill burden, but quality of life and adverse events related to beta blocker have been touted as one of the other reasons to get beta blocker off of the plate. And there is no difference in quality of life. So I think that if there's been an indication for beta blocker, originally an EF below 40%, even if their EF is recovered, I would wait at least arbitrarily until 1 year's time and then reassess. But we don't have any evidence base to support that strategy. But that's what I would do clinically.
That's great. Thank you.
All right. Any other comments or questions about beta blockers? If not, we'll move on to the arena of atrial fibrillation. And this is a neat study that has some Canadian roots. Chris Chung is the second author, our colleague at Sunnybrook. This is the DCAF trial. Does eliminating coffee avoid fibrillation, atrial fibrillation? So they certainly win for the best acronym. Let me advance the slide here. The background I'm going to skip over fairly quickly. There's been some debate over the course of time whether coffee can lead to atrial fibrillation or be a trigger or exacerbate AFib and other arrhythmias. The guidelines, actually, at least the American guidelines, suggest that caffeine abstention may be important in patients who report caffeine triggers or worsen AF symptoms. There are observational studies. Some say there's more AF, some say there's less AF, and there's been some N of 1 studies that this same group has investigated to suggest that it doesn't appear to be a trigger necessarily. Then finally, Greg Marcus has done some work in an ambulatory patient population and done 14-day Holter monitoring, for example, to suggest that there may be an increase in the risk for premature atrial contractions and certainly PVCs when people consume coffee on a regular basis. But that's all speculation. Really, observational studies are confounded, and so we need randomized trial evidence. And so they took patients with sustained atrial fibrillation or flutter who were planned to undergo electrical cardioversion and had been consuming some sort of coffee over the past 5 years' time. On average, it was about 1 cup a day. And there were 5 hospitals in the U.S. Chris Chung at Sunnybrook was one of the sites. Australia was the other location, together with the U.S. And they randomized patients to consume 1 or more cups of coffee, caffeinated coffee, per day, or the other half of the group was to abstain post-cardioversion from all coffee and caffeine-containing products. This is the patient population, on average about 68 to 70 years, a third to 30% or so were female. And this is a look at the coffee consumption versus coffee abstinence. You can see there's some standard deviations. Not everybody in the coffee abstinence group necessarily admitted that they did consume some coffee, but there were some. And so the good news is that on average there was about 7 cups per week, or 1 cup per day. And there's a contrast in coffee consumption versus coffee abstinence groups. Now, interestingly, their primary outcome, which is the recurrence of atrial fibrillation, which was picked up by a variety of clinical ECGs that were done clinically and Holter monitor recordings, but wasn't mandated. So that's one of the limitations of the study. But most people had some sort of surveillance for recurrent atrial fibrillation. And you can see that, if anything, in blue, the coffee consumption group was at a significantly lower rate than the coffee abstinence group in red to have recurrent atrial fibrillation or flutter. They also did a sort of untreated analysis to try to identify those who truly were completely abstinent from taking in any coffee. And if anything, there's an even lower hazard ratio. So very consistent in an on-treatment, as best as one can estimate it, analysis. There's obvious limitations. As I mentioned, there were multiple different methods of detecting the primary outcome, and it was all clinically driven. And so it's possible that there could have been some asymptomatic atrial fib flutter that was not picked up because patients weren't routinely and consistently wearing continuous recording devices. But in general, it's interesting to see that random allocation to consumption of caffeinated coffee resulted in less atrial fibrillation and flutter compared to abstinence from coffee and caffeine. So this was published simultaneously in JAMA, and I would argue that maybe post cardioversion at St. Michael's Hospital, you should then go to Tim Hortons to grab your daily cup to reduce the occurrence of atrial fibrillation. So let me stop and see if anybody has any comments about caffeinated coffee consumption post atrial fibrillation. Again, this is not suggesting that if you've never had caffeine that you should now actively post cardioversion start coffee. But remember, these patients had on average they were drinking at least 1 cup of caffeinated coffee before they were randomized to either abstain or continue their coffee. Comments or questions?
Shaun, yeah, great, and good to see Chris in this space. It's an interesting area. I mean, do we think the hypothesis is that if you go to the abstinence, you might get withdrawal, and that could then trigger sympathetic? Do you know?
Right.
I wasn't at the session. Do you know what people thought? Why?
Yeah, so it's a great question, and so the investigators were asked that, and they also talk a little bit about it in their JAMA paper. They don't think that this is mainly driven by withdrawal, because the timing of when the recurrent atrial fibrillation happens is not all early, and they did some additional analyses to try to look at those, because everybody in theory would have been on average a daily, a cup of caffeinated coffee, and so they looked at the time window based on the half-life of the caffeine effect, and didn't really see this was not an early phenomenon, and so while they can't completely exclude withdrawal as a trigger for a higher rate, in other words, it's more a withdrawal effect than actually drinking a cup of caffeinated coffee a day that's quote unquote protective or prevents atrial fibrillation. It's a great question. It's a great potential hypothesis, but everything in their data and their analyses suggests that this is not an effect of withdrawal, but potentially a protective effect, so to speak, of daily caffeine ingestion. Great question. Other comments or questions as everybody thinks about buying a Tim Hortons card? Okay, let me go back to atrial fibrillation, but in a little more serious note, talk about antithrombotic therapy following in patients who have had an ACS or who have undergone PCI. And so I shared with you post ESC the very impressive aquatic study from the French investigators where they did a double-blind randomized placebo-controlled trial in atrial fibrillation patients who had concomitant coronary artery disease and had undergone 6 months or later previously had undergone percutaneous coronary intervention, stenting. And so the question is, once you're, let's say, 6 months out and beyond, should you, and you have atrial fibrillation and you need oral anticoagulation for stroke and systemic embolism prevention, should you continue any antiplatelet therapy? So this is beyond the period of dual antiplatelet therapy, but should you continue a single antiplatelet therapy? And so this trial was actually stopped prematurely by the Data Safety Monitoring Committee because not only was the primary outcome in favor of oral anticoagulation alone and dropping aspirin, mainly because of less bleeding, but also all-cause mortality was significantly lower in the OAC monotherapy group compared to OAC together with aspirin. So again, AFib patients with concomitant coronary artery disease, and so aspirin or any antiplatelet therapy here does offer nothing from an ischemic event perspective, increases the risk of bleeding, and increases all-cause mortality compared to just going with oral anticoagulation as monotherapy. And here's the bleeding differences, but also the all-cause mortality differences. So there were 2 more trials that were presented. one from Korea, and one from Japan. This is the ADAPT-DES study that looked at just under 1,000 AF patients requiring long-term oral anticoagulation therapy who underwent drug-eluting stent implantation 12 months or later from the time of randomization, and they were randomized to NOAC monotherapy versus NOAC plus, in this case, replacing aspirin, they used clopidogrel as the single antiplatelet therapy. And so, unsurprisingly, if you add an antiplatelet, in this case clopidogrel, to the NOAC, you have more bleeding, and that is the main driver of this net clinical adverse event. So major bleeding or clinically relevant non-major bleeding, unsurprisingly, more frequent with combination therapy compared to NOAC monotherapy on its own. They made the argument that there was no difference in ischemic endpoints, including stroke and systemic embolism, and so suggesting that the NOAC monotherapy would be protective enough and is obviously associated with less major and clinically relevant non-major bleeding, that the net clinical benefit is in favor of just going with NOAC monotherapy. Now, I would argue that they're underpowered to be certain that ischemic events are not more frequent in the OAC or NOAC monotherapy group, but they were able to get this under 1,000 patient trial published in the New England Journal of Medicine, and it adds to the body of evidence that we have in this space. And then the other study that was not published simultaneously was from Japan, called the Optima AF trial. They looked at an even earlier time frame. So this was CAD patients, about 1,000 of them, who also have atrial fibrillation, who need oral anticoagulation therapy. And so for the first month they received, following their PCI, they received dual therapy. In other words, they received both an oral anticoagulant and at least a single antiplatelet therapy. But then at 1 month's time, they were randomized to receive just the DOAC-NOAC monotherapy. In contrast, the control arm got after their first month of whatever combination of oral anticoagulation and antiplatelet therapy they wanted, they then received, from 1 month out to 12 months' time, they received a dual therapy with the DOAC and a P2Y12 receptor inhibitor. Here's the patient population. It's obviously older. I do want to point out that they only had a small percentage of so-called acute coronary syndrome. They actually excluded MI patients, but they included unstable angina patients. But the vast majority of these patients, 95% of them, were a chronic coronary syndrome population. So the PCI was in a chronic coronary syndrome, not mainly an ACS scenario. And that's probably one of the reasons why they were willing to have a very short duration of antiplatelet therapy and randomize one of the groups to receive monotherapy from month 1 to 11. Here's the list of the antiplatelet therapies. Here's the list of the direct oral anticoagulants. You might be surprised to see edoxaban as one of the most common NOAC therapies, but remember, Daiichi Sankyo is the worldwide maker of edoxaban, and Japan is the home of Daiichi Sankyo. So that's the most commonly prescribed NOAC, DOAC in Japan. Now, they ultimately set their non-inferiority margin for their net clinical benefit at 5%. So that means that as long as the monotherapy arm or the dual antithrombotic arm was no worse than 5% difference, then they could claim non-inferiority. I would argue this is much too large from a bleeding perspective or an ischemic event perspective, a non-inferiority margin. So they did show a clear difference, and arguably they could say they found that monotherapy out to 12 months' time was better than dual therapy out to 12 months' time because major bleeding is substantially different. But it's unclear from an ischemic endpoint and an embolic endpoint perspective whether it's, I would argue, completely safe to drop an antiplatelet as soon as 1 month's time. And they didn't even achieve their expected ischemic event rate. And so remember, with non-inferiority, the fact that there's not a statistically significant difference in an underpowered trial does not mean that you have good evidence for lack of a difference between these two strategies. And so I guess the bottom line of these two trials added to the aquatic study is that the Canadian Cardiovascular Society atrial fibrillation guidelines have it right. And that is that if a patient has an ACS and or undergoes PCI, there should be a very short period of time of so-called triple or even dual antithrombotic therapy. And as soon as the risk of stent thrombosis is felt to be acceptably low, then patients should come off all antiplatelet therapy, and their secondary prevention of their coronary or vascular disease should not include any antiplatelet therapy, but full dose oral anticoagulation therapy that will cover them for their coronary or vascular secondary prevention, but will also be the optimal therapy for preventing stroke and systemic embolism in patients who have atrial fibrillation. So let me stop there and see if people have any comments as it relates to monotherapy for oral anticoagulation in atrial fibrillation and concomitant atherosclerotic cardiovascular disease. Any thoughts or comments about that? All right, well, I'll just as an anecdote say that I continue to come across patients in my own clinical practice who have atrial fibrillation and coronary artery disease. Often they've had coronary artery disease first, and then subsequently, as they age and with the risk factors, hypertension, etc., they develop atrial fibrillation. And it's really important to get these patients off of their antiplatelet therapy when you transition them to oral anticoagulation therapy. So I'm still finding patients in my own practice. So please, a plea here. I think it's fairly consistent evidence and very strong evidence now to support the guideline recommendations that we're doing patients a disservice, not only from a bleeding perspective, but from the consequences of bleeding in terms of cardiovascular events if we don't get them off of antiplatelet therapy. Okay, so the last trial that I want to share with you, unfortunately, is not published, and getting a hold of the slides is not an easy thing to do, but I think this is a really important study to be aware of. And there's another trial in this space that's coming out at the ACC, so we'll see. This is not arguably yet practice changing, but we know that left atrial appendage closure or occlusion devices could be offered to patients instead of, for example, oral anticoagulation in atrial fibrillation, with the idea that since the left atrial appendage is the common site for atrial thrombus formation, if we can occlude it and take it out of the picture, then maybe patients at high bleeding risk who cannot take or cannot tolerate oral anticoagulation therapy, maybe this would be a mechanical way of minimizing the risk of stroke and systemic embolism. So that's the theory, and there's a bunch of devices that have been approved for use. When we look at trials that actually compare the two, not in patients who are ineligible or who can't take oral anticoagulation, but comparing left atrial appendage closure devices with oral anticoagulation, there's relatively limited data, and these are all in patients who are eligible for oral anticoagulation. These are the 3 randomized trials that have been done so far, all of them have demonstrated non-inferiority for efficacy. But none of these trials have included patients who are on oral anticoagulation and are at high risk of bleeding. And so the CLOSURE AF trial was led by Ulf Landmesser and colleagues in Germany, and this was presented at the AHA. The design paper was published most recently, and basically randomizes patients who have non-valvular atrial fibrillation, who have a CHADS VAS score that warrants chronic oral anticoagulation therapy, but these patients are at increased bleeding risk, as defined according to the conventional HAS-BLED score or other BARC-like criteria. And so these patients are randomized to receive a percutaneous left atrial appendage closure device or quote-unquote best medical care. And so the best medical care group is essentially recommended to receive oral anticoagulation, and the left atrial appendage closure device, depending on their bleeding risk, will have as short a duration of antiplatelet and or anticoagulation therapy as possible. Remember, once these devices go in, there is a period of time where they need some sort of antithrombotic therapy to minimize the risk of clots on the foreign body that's sitting in the left atrial appendage. So interestingly, in the left atrial appendage occlusion device population, it was attempted in 94% of those randomized to the LAAC implantation arm, and device success was realized in 98%. But of the 414 attempted procedures, 5 had tamponade, 18 had major bleeding requiring transfusion. There's 1 device embolization, 1 procedure-related TIA, 1 peripheral embolism, and 2 deaths that occurred within 7 days of the implant. So while there can be technical success, the challenge is implantation of these devices is not without adverse events. Now, if we look at the antithrombotic therapy, you can see that the majority of the patients assigned to best medical care to not have a device put in place were on DOACs, but there's a smattering of combination with antiplatelet therapy as well. So the primary outcome, which is stroke, systemic embolism, cardiovascular or unexplained death, or major bleeding, so a net clinical benefit, did not show any statistical difference between the two arms, but you can see that the left atrial appendage closure device in red seemed to be worse off numerically compared to the best medical care, i.e. essentially the antithrombotic care group. And this is again because the risk of adverse events, including bleeding, including stroke, including death, is numerically higher in the left atrial appendage closure device. And here's the details of some of those that I already outlined. And so they concluded that the strategy did not achieve non-inferiority of putting in routinely left atrial appendage closure devices. And I would argue this is a well-done study. It was not industry funded. These were experienced centers that were doing this procedure long before it was even approved in the United States, and they had high procedural or technical or device success. So this is really the best case scenario, and yet the complications related to the left atrial appendage strategy means that the device is ultimately going to have to overcome this upfront risk of the procedure. Otherwise, it's hard to imagine how even over the course of time, a risk of bleeding with oral anticoagulation will be overcome. So this, I think, is a sobering preliminary, not yet published, and there are a number of other trials that are in this space as well. But I do think it should give us pause in those patients who can potentially go for oral anticoagulation even if they're at high bleeding risk. Obviously, if a patient has tried and has recurrent bleeding, left atrial appendage closure device is reasonable to think about. But if a patient is even at high bleeding risk for oral anticoagulation, I would say we should think about continuing that, biting the bullet, versus putting in a left atrial appendage closure device. So I'm going to stop sharing and open up to any questions or comments, particularly maybe some of our interventional colleagues might have related to the closure AF trial. And that's just a quick summary of the takeaways.